phone calls from dentists who are outraged, which suggested she touched a nerve. But what good does it even have if you had coverage if no dentist will take you because you are poor? And it's not that you're getting only 80%, that they don't want you in their waiting room at all. Right. And it's just an outrage. And journalists can have an immediate impact on that kind of thing in terms of opening up access. It should be more embarrassing not to take Medicaid patients than to have a Medicaid patient in your office.
I teach community journalism. I was a weekly newspaper editor before I worked at the Courier-Journal. These kinds of questions are so difficult for community journalists to ask that they don't ask them. But folks, we're talking about people's life and well-being here. You know, you shouldn't be embarrassed. Call up every dentist in town and say, do you take Medicaid? And if you don't, why not? You know, there are some dentists who will take Medicaid, but only on Wednesdays or whatever, because they don't want the Medicaid patients interacting with their regular patients.
And they take Wednesdays off.
Yeah. It's a story. You know, do the public good. Help your folks out.
I just wanted to also say that psychiatrists fall into this category as well, and a lot of them actually won't take any insurance. So, you know, that's another story too.
I think part of, making the healthcare story less complicated is making it personal. Do you have strategies for getting around HIPAA laws for finding sources for your stories?
Great question. Mary, anything you want?
I mean, I think that is a challenge. Like, personally, my sister signed up for insurance under Connect, and it was a disaster for her. She has a heart problem. She has cancer. She couldn't get her medicine straight. She couldn't get her doctor straight. She went without insurance for a while, but I couldn't write about her because she was my sister. So I think you might have some better luck in communities where you're closer to the ground, because maybe you can ask people at your church or people, that from the gym or wherever, to share their stories. And they might be more willing to, because you are the face of somebody that they see, in the grocery store or whatever. If people want to tell you their story, there isn't any HIPAA issues. But getting the hospitals, it is a very big challenge.
I do a lot of personal stories. Like one, I've been following a woman who's dying of breast cancer over the time that she's still living at this point. But so I try to do kind of narrative stories, kind of telling a larger issue through people's lives. And one thing that, actually I have two strategies that usually work for me. A lot of times these organizations like the Alzheimer's Association, American Heart Association, Cancer Society, if you just say, I really would like to talk to a few breast cancer patients, they'll get you some, and you just call them, and if they want to talk to you, great, then can I meet with you? Can I meet you at your house? And so that strategy actually, through the Alzheimer's Association, I met a family with a man who eventually died of Alzheimer's, but I spent 6 years with this family. And found them through the Alzheimer's Association in Louisville. So that's one thing. Also, I also just ask doctors. I say, can you just give my name and number to your patient, and they will. Yeah, I've never had a doctor not do. Yes, not all the time, but certainly. Sometimes, and I think it works better the more local you are. So that's a real advantage of being sort of a hybrid local national person, because I can get local doctors who know me and worked with me for years to be like, oh yeah, I trust you. I'll put in a good word for you, etc. So, but you all are local folks, so that should work for you too.
Two other strategies that come to mind for me is I find that the community health centers tend to be much less living in fear or whatever, like using HIPAA as a defense mechanism and as a way to keep you out of their clinics and out of their environment, and much more willing to do what it takes with whatever consent forms you need, but also, I find that so many hospitals almost try to talk their patients out of talking to us as reporters using HIPAA as a reason. And the community health centers, it's not that they try to talk them into talking to us, but they are much more objective about it. And I think the patients there, I have just had a lot more luck getting access to patients there, even within the confines of HIPAA. The other thing that the New York Times has had some success with, partly because we're so big, I guess, is social media and using Facebook and Twitter and also just our website to solicit stories from people. And I don't know, I would think that all of you would have some opportunity, whether with Facebook, like maybe a community Facebook page or something, to say, hey, I'm a reporter for such and such, and I'd really love to connect with some people who are in this situation, and here's how you reach me. Sometimes it works beautifully, sometimes it doesn't work at all. But we've managed to build a database of probably hundreds of people with ACA stories that I dip into now and then to find anecdotes about people who can't afford their deductibles, or people who got had to write a big check at tax time because they ended up getting too big a subsidy for their income and they had to pay some of the subsidy back, or a bunch of different situations. So definitely don't be afraid to at least experiment with using social media to find people.
I just wanted to say too, another strategy that a lot of USA Today people use is put a tagline at the end of your story. I'm looking for people. Tell us your ACA story or whatever, and you'll always get people.
So I want to just suggest real quickly as somebody who's older than at least 3 of our 4 other panelists, I wrote a long series on privacy concerns in the pre-HIPAA era and worked with the people who were writing HIPAA, and I can assure you that they didn't intend HIPAA to work the way it did. It was intended to protect against the nightmare violations of patients' privacy, not to protect hospitals against having their patients blow the whistle on them. And a couple really quick low-tech and high-tech ways around HIPAA. One low-tech way around it is when we were doing a series on hospital errors and had patients dying and asked the hospital, who are these patients? We want to talk to the family. And they, of course, refused to tell us. Using everything from county death records to obits in local newspapers, you knew the dates because the sanitized reports at least had dates, and there weren't that many people dying of whatever the condition was, and it was easy to do that. I also think that I wish I had been a reporter, and I'm glad I'm doing books in an era of Accurant, because it is anybody who doesn't have access, everybody knows what Accurant is, the People Finder site. It is the most extraordinary way of violating everybody in the world's privacy on how to track them down. If you know somebody's name and you know their approximate date of birth, and you have a friend at a newspaper that has a subscription to Accurant, which everybody in Boston does, and I assume there are lots of papers and other outlets here that have it, it will let you, if you know an approximate age, it will tell you every place that person has lived, every phone number they've had for the last 10 years. It is a way that the most untrackable people in America are now able to be tracked. So it's ACCURINT. The New York Times has a subscription?
Yeah, we get it through Nexus.
Through Nexus. You have... Great. So here are friends who can give you... I have somebody's password, unnamed person, but they're an extraordinary way to find people.
And that's not only the only service like that. I mean, if you go to switchboard.com, you'll find a similar service. It's not as good.
Right. It's not as good. So there are free ones, and then there are ways of doing it if you have a friend who has.
Okay, I'm sorry, I'm squeamish. I do PR for UK Healthcare, so I just want to clarify that as within HIPAA regulations, we want to share our patients' stories. We want to connect journalists to patients. And often the patients see this cathartic value in sharing their stories. You all know that better than anybody. But in response to that, I think it's important to approach a patient's story, and I would like to hear your all's take on this with empathy and compassion whenever possible. I haven't heard really much talk about how you approach this patient stories. I've read all 3 of y'all's work, and I know you all do that. But I would like to ask you all about that approach to a patient instead of seeing this as like trying to circumvent HIPAA violations, but actually working with the patient, engaging the patient, and bringing meaning to a health issue. I know you all have been successful, so I'd like to know how you have done that.
Well, I would like to make a suggestion. Who can't see your face, so who are you from UK? I didn't hear. Elizabeth. Oh, hi, Elizabeth. I think one of the things that the healthcare providers can do is not only limit patient access to press conferences where you've got 10 journalists in a room on a Tuesday at 1 o'clock, and the press conference is going to last a half an hour, and we're supposed to get their personal story and impart a great meaning. I mean, I just think the way that those are set up are really, they're really not conducive to telling those stories and giving those patients the respect that they deserve. Also, to make available for those of us who ask for more time to speak to those patients, a space that is quiet and private, and not, I mean, I've interviewed several patients in the lobby of UK, that big cavernous, main lobby, which is terrible for trying to talk to someone about their life and death situation, I feel like. So, and I think if you're still in journalism at this point, you're not slapdashing and not paying attention to people, and you're not going to get a good story if you don't ask them to be honest with you and aren't compassionate towards them. I do think sometimes it can be helpful if your subject is hesitant to talk to you, to meet with them, just to meet you, to put a face to the name that they have so that they can decide whether you will do their story justice, and to give them the out that, well, let's have coffee and let's just talk about it and see if you feel like it's something you want to tell.
And to a couple of those points, I think that meeting in some of those kind of, the hallway quickly is usually not good. So what I try to do whenever possible is to meet them at their home or some kind of setting where their hospital room or whatever, where the story is taking place. That way they get to know me, I get to know them, and I see them, in their, kind of, where they are versus a quick meeting in a hallway. So I do find that is the best way to engage people, and they feel more comfortable. If they're at their home, they feel like they're comfortable there. So that's one thing. And as far as like kind of getting people to talk or getting people to share their stories, what a lot of times works, and I think people not only want to tell their stories for the cathartic reasons, but they want to help other people. I mean, that's really what it comes down to, that they feel like, okay, if I share my story, maybe someone else wouldn't have to go through this terrible thing, or they can learn from, how I have dealt with it, and I could maybe inspire somebody else, and it's really true. I mean, they really feel that way. So that's, I a lot of times will appeal to them, speaking out, could really, show others the way, and it's true. Because like whenever we write those real personal stories, I mean, I get tons of calls, and these people become almost personal friends of the readers, so you really are doing that. You're being sort of a conduit for them to help others.
One other thing I would say on the empathy piece, I think all of us as healthcare reporters have kind of, one of the reasons we do this healthcare reporting is that we do have empathy, and that ability to sort of see both sides and relate to people and understand, be sensitive about all the complications of and also how personal people's health is. It's the most personal thing that you can share with a reporter, I think. And so it is a huge ask to ask people to share their stories with us. But I think, like Laura said, it's something that a lot of them really do want to do, partly to help other people. I hear that again and again from people I talk to for healthcare stories. But one thing I would say is when I get a sense that somebody really is uncomfortable sharing their story and is not going to be okay with it for some reason or other, I walk away. I might press them to an extent, but the minute I get the sense that they're deeply uncomfortable sharing their story with me, I drop it and let it go because, like I said, I feel like healthcare and your health is the most personal thing that you can share. And I want to make sure that somebody's not going to deeply regret having their story out there in front of 1 million+ people.
I've done the same thing in telling people that it was clear that they weren't quite ready to tell their story. I haven't done it very often. But I had a family who was talking about their son's suicide. I spent 2 hours and an afternoon talking to them at their home. And the next day, the father called me concerned about how something would be presented. And in the end, I was like, if you're this uncomfortable now, I'm just concerned that this story is going to do more harm than good for you. And we ended up not writing it. So I agree with what she said.
So I spent a lot of years teaching journalism students, and the one thing that I tried to convey more than anything else is that for all that journalists are in the business to try to change the world for the better, what we have more potential to do and more demonstrable is to ruin somebody's life if we're telling a story that they don't want to be told. And you all are smart enough to know that, but it really is important to remember that that no matter what our motivations are, we should be careful not to do that kind of harm.
Well, I did, but I think we've moved on that. Quickly, mine was not about HIPAA or trying to get around HIPAA or anything like that, but more on strategies that you guys were talking about a little earlier. The Foundation for Healthy Kentucky obviously wants to be part of the strategy, and you can call us. We are a source for independent, reliable, objective health information and data analysis, and also as a connector standpoint. So if you're looking for someone on a regional or national scale who may have done a study on a particular issue, maybe we can connect you to that. Or if you're looking, like for someone from Pew or Robert Wood Johnson Foundation, et cetera, et cetera. So that's something that you can have at your disposal as well. And if somebody calls about wanting the story, I might say, well, I know that Kentucky Voices for Health and Emily Beauregard have done some story banking. And they may have that story, the Eli that you're looking for over in Hopkinsville, or they may have the story in Glasgow or whatever the case may be. But again, we just want to be kind of a part of the loop there, and we can help.
So,
I'm an extension professor.
yes.
My job, help people who need help. So don't hesitate to call.
So do call him, and we're going to give out everybody's email address before we end the session. But I want to suggest one other thing, and Doug won't like my saying this, but one other thing to think about foundations for is not just as a resource or to point you to other resources, but it is for money. And there are not every foundation will do this, but these days, if you're a journalist at an outlet that is stretched for resources and you need more money to go do a great project, there are often foundations out there that will do that. And I got my first foundation grant when I was at the Courier Journal, and it was the first time they'd ever accepted money from an outside source, but we were trying to do an ambitious project on the environment, and it was back in the Bingham days when they had a lot of money, but they said, this foundation is willing to give us money, and we rented a boat to take a bunch of experts down the Ohio River to do a series on river pollution, and it was clean money, and it was money that came for that specific purpose, and the foundation, but if you don't have money to do an ambitious project that you want, ask somebody for the money, and you'll often find a way to get it. And write down one website, which is called, for $30 a month, you can sign up for Foundation Center Online. and it is a guide to every foundation in the world. And if you plug in journalism and pollution on the Ohio River, it will tell you every obscure foundation out there that ever has funded anything like that. And you will be amazed if you were a foundation and you had a choice of funding somebody to do a study that was going to be in a library that nobody was ever going to read, or funding a journalism outlet that was going to give high profile to the same issue. It can be made to be very attractive to a foundation to fund you and your journalism project.
My name's Stephanie. I'm with the Messenger Inquirer in Owensboro. I've been on the health beat since the beginning of the year, pretty much. And, there's no shortage of local, events and local coverage. But when it comes to localizing like the big national stories, like the Affordable Care Act, it can kind of get overwhelming to figure out how to kind of narrow it down to a local community kind of level. Or do you have any suggestions or tips, or maybe like what's the most important thing to maybe keep in mind when you're trying to localize something that's so big and encompassing?
You have to narrow your focus first. What facet of the Affordable Care Act are you going to explore? Usually timing is important. Right now we have a governor's race coming up. There are aspects of that deserve exploration. Right after that, you have as the election begins, you're going to have the opening of qualified health plan enrollment through Connect. That's a public service angle to explore. The legislature comes on in January. So make it a matter of focus and timing, and always, look for local people who can help you out and localize it. In a town like Owensboro, you shouldn't have any trouble.
And I agree completely with all of that. I also think, like, if you kind of think of it as, writing to a reader, what does that reader, that one person, need to know? Not like all the arcane things that, so write to the reader. Also, I mean, as I was saying before, we did something looking at Floyd County, basically, the Affordable Care Act and views of its implementation through the lens of Floyd County. You could do the same thing with Owensboro, or one aspect, or even one neighborhood, or zip code or something. There's a lot of possibilities there.
The other thing I guess I would say is I like Al's advice about sort of following the calendar and finding things to write about, time to open enrollment, and then like in December, it'll come time for everybody to either choose a new plan or renew their plan for next year. And are their rates going to go way up, or are they not? How's the affordability issue playing? Then in April, you have tax time and you have the bigger penalty setting in. You can obviously do a local story about the effects of the tax penalty, the quite bigger tax penalty next year. So just trying to keep a calendar of all the important things that come month to month regarding the Affordable Care Act, and kind of time and plan stories around that. And the other thing I would say is just take to lunch or coffee or whatever as many people involved in this in your community as you can. The connectors who sign people up, the brokers who sign people up for plans, the doctors in the community health centers or the primary care clinics who are treating them, asking them what issues they see coming up with regarding the Affordable Care Act with their patients, and asking them to connect you with patients. Just try to talk to as many people who are on the ground and have their sleeves rolled up and are really involved in making this thing work as you can in your community.
I would suggest
Sorry, Mary.
I'm sorry. I would also suggest just not to be intimidated by the fact that it's the Affordable Care Act and it's this huge, enormous thing that, so many people don't understand at all, and to focus, as she just said, on the personal stories that are available in your community, because at its heart, the Affordable Care Act is how people take care of themselves and live their lives and how they take care of their families. So just don't let the specter of this huge government program keep you from looking at it as the good journalist that you are and looking for the stories in your community that you can tell.
And I just want to piggyback quickly on two things that Abby said. There are two kinds of calendars that you ought to sort of have on your wall or in your head. One is the bureaucratic calendar of what's coming up in terms of deadlines for the Affordable Care Act. The other is the real calendar. As a health reporter, people focus on certain kinds of stories at certain kinds of times of the year. So every point in my health beats, when we were getting from winter into spring, I would do a skin cancer story. There were certain stories that your general reading public cared about because that was goodbye, Nora. There were certain calendars like that mattered. I also think that her idea, everybody says it and nobody ever does it. Taking people to coffee is an interesting thing to do for a lot of reasons. And if I were you, I assume you've got one or two hospitals in your area. I would go through, get to know and own the communications people at your hospital and take the CEO to coffee before there's a crisis that you need that CEO, so that you know them and you've asked them for their home phone number and their email and all the things. Communications people block your ears because you hate when people have that kind of direct contact. But if you do that kind of thing pre-crisis, then crisis, they will be available to you and nobody else because nobody's going to know how to reach them.
Outside their work environment, like get them away from their desk. Don't be you sitting on one side of their desk and them on the other and having this official back and forth about what's happening with the Affordable Care Act. Get them out somewhere where they can relax a little, even if for 40 minutes, and feel like they're out of their work environment enough to actually tell you some interesting stuff.
That they feel a lesser obligation to their institution, and you just get them to loosen up a little bit, and they probably have a little less leverage because they're not on their turf.
Last night we had a very small dinner of a few old friends from the Courier Journal, and Al was one of them, and somebody who ran an important agency in this city was there telling us about an inside story and a scandal. And I don't know how many bourbons Al had at the time, but the person who was telling us about the scandal had at least a couple. And I think it really does help getting them outside of that contentious environment. And what it also does is if you should have, by the end of your year or two on the beat, everybody's personal email and cell phone number and all those things. And there was a guy at the Courier Journal when I was there, which was 200 years ago, who is still there, shockingly to me, named Sheldon Schaefer. And anytime I didn't have somebody's email or telephone number, he had 3 of them. And so get to know at your own publication the people who had your beat before you did, because they probably got all that stuff and would share it with you. And so question over here, we're going to come all the way around here, but
Eli Pace up in Hopkinsville, Kentucky. We're in western Kentucky, where we have some of the worst health statistics out there. Now, working there on a daily basis, I don't think that it's a lot of times conscious decisions. There was a question earlier that I felt really kind of got to the heart of a lot of these statistics, and it was about the culture. And when you look at Trigg, Todd, Christian counties, I'm not sure that we're always making decisions with our health in mind. And a lot of those decisions are being made by people at the very lowest rung on the economic ladder. I think that when you're getting off work, trying to get the kids to school before you go to your next job, you're living in a food desert, you're not always thinking of, what's the most healthy thing that I can do. I was wondering, have you guys, through your reporting or experience, seen any communities that have moved the health needle as a whole, not just individually, but as a whole community, without the socioeconomic indicators coming along with it, education, income?
I've had long enough time to search the rural blog, which I published. I could probably find you one, but well, I don't know. I think you can talk to people directly about health, but you have to sort of talk to them in their own terms. researchers at UK used to have a real problem getting into local communities and having some impact. And they found finally that the best way to get into local communities and have an impact was go through the churches. And that, in that particular community that you're referring to, especially in Hopkinsville, I think, that's a good entry point.
You mentioned success stories. I mean, one thing that has had some modest success, there are these healthy corner stores in food deserts. You mentioned food deserts as well. Louisville has these, and actually I was just in Houston last week doing some stories from there, and they are piloting theirs, and they looked at Louisville, and so there are lots of things like that where health departments a lot of times, especially in the bigger cities, are trying to deal with some of those equity issues. And some things are more successful than others. But I think maybe if you start with the health department and say, how are you dealing with health equity? Give me your statistics on how this was before and how it is today. And, are people eating more fruits and vegetables in this neighborhood? And what do the, cardiovascular disease statistics look like by zip code? And like Louisville has all that kind of information. So I would start maybe with something like that.
I don't have much to add to that. I would have the same advice. I was reminded last week I was in the Mississippi Delta, driving along this rural road, and I saw a billboard that some advocacy group had put up advertising a small rural community that had undergone some sort of plan to improve everybody's health with diet and exercise, et cetera. And it was all these people who had lost a ton of weight and were eating better, et cetera, pictured on the billboard. And I don't know who it was or what it was, but it might be worth finding programs like that in towns that have tried to go all in on improving everybody's diet and exercise, et cetera, and just seeing how it's worked out.
I would add that you're hitting on a really important question, and actually that was my proposal, a study for coming up here, is that now everybody has insurance or will soon. How do you get them to actually use it to better their health? And that is a very difficult cultural question. It's very involved. But I think there are some success stories in Kentucky as a whole. There's a part of Kentucky that they have one of the greatest changes in health measures percentage-wise in the country. And it could be that they were so bad to begin with. So there are some things that are happening for the good, and I think you have to look at your community and find out what those are, and then ask very specific questions about what's working. And in the end, people need to eat less and exercise more and take their medicine as prescribed. But getting them to do that is a challenge, and there probably are some people who are having successes in your communities doing that.
Can I just add a couple quick things that I would do without knowing your community at all? But I would go. Laura had a good suggestion going to your public health department. Often the person who heads a public health department is a politician, and I would go get to know the epidemiologists at the public health department, the people who really have the numbers. And it may be numbers the department wants out, or maybe not, but bore down a little bit to the people who really know that stuff, and go to the nearest university with a medical school or with a public health school and ask the epidemiologist there, and then at a macro level, go to the Centers for Disease Control and ask the smartest communications person there, who are the epidemiologists in America that would have it borne down to a community level where they could tell you the healthiest community in Kentucky. And I assume that somebody somewhere has some data on that, and it would be wonderful to know that. And when those become the hottest stories in Massachusetts, Nora Volkow, the reason she was here today was because at the session she did in Washington, she mentioned 2 states that were the worst states that she thought in America in terms of the opioid epidemic. And today she called you one of 3 or 4 and named others. At that time, it was Massachusetts and Kentucky. And those are 2 states that you don't often see linked together on many things involving health issues, because Massachusetts is normally number 1 or 2 or 3, and Kentucky's normally 48, 49, or 50. And there is a community, if you're ever interested in a community outside of Kentucky, that every reporter in Massachusetts is now using as a model of how you solve things there. And it's a magnificent little coastal community that nobody would ever thought as a model for anything, and it's called Gloucester, Massachusetts. And I can't tell you all the details of what they've done, but their mayor has made it a passion to take on the opioid epidemic. And if I were in any other community that had a big problem, I'd be saying, why aren't we doing what Gloucester is? It would be better if Gloucester were 5 miles from you rather than 1,000, but you just want models of how to do it better. There are, but don't trust the politicians telling you that they've done it. Trust the epidemiologists telling you that they've got results on it. Sure, Al, just before we do.
In Hopkinsville, you've got a racial equation. I mean, that's the community, possible exception of Louisville, of the largest African American population in the state, and it's an alienated community in many cases. So I don't have any really good examples on that point. But if you look at the county health rankings, which come out every March, end of March, you'll find certain communities that have really bad indicators, but fairly good outcomes. You know, nobody has really studied these communities to figure out what's going on there. These rankings have only come out for about 5 years, and they're just now beginning to get enough data points to where they can really be reliable for research. But if you look at Morgan County, it always ranks in the bottom quartile, the bottom fourth of indicators. People smoke, they're obese, and so on. But it's always in the second quartile of outcomes. Somehow they overcome the indicators. And why that is, I don't know. They had a big effort for community health about a decade ago that a UK researcher went there to do. Might have had some impact on it, but there's something going on in that county. Maybe they have an Appalachian Regional Hospital, which could have had an impact. But if you're looking for examples of how communities can overcome the cards that have been dealt them, then I would suggest the county health rankings. I'm sorry? Yep. Well, those rankings are done for every county in the country, and you can probably find a few, and enough searching, you'll probably find one where there's some scalable or something that resonates in Christian County.
You, so I would have just come to you directly, but my colleagues over in the communication department at the University of Louisville received an NIH grant to look at some of the things you were talking about, and they did it in Hopkinsville. So if you see me afterwards, I can give you their information, and they ask questions, and they did it with the African American community, to Mr. Cross's point, and they ask about fruit and vegetable consumption and other questions that I think will be of help to you.
It's a nice example of networking across a room.
Thanks. Hi, my name is Amber Duke. I'm the communications director for the ACLU of Kentucky, so I know never to have bourbon without Cross if you invite me out for bourbon. I have a question for the panel about the challenges of covering perennial health issues or any pushback that you get from your editors. And I'm thinking specifically about reproductive health issues, access to abortion. You all were talking a little bit about the calendar that, reporters can plug into and follow. And I find that obviously, with everything that's been going on with Kim Davis, I have received, no shortage of calls from reporters literally around the world, day and night, text, asking what's next, what's happening, what's going to happen next, looking for the next creative angle of how they can keep advancing that story. But when it comes to access to abortion, we get the stories that happen right before the legislature, what's going to happen. The legislature starts, and it's just sort of covered like it's kabuki theater that happens. There's not a lot of in-depth coverage that happens. And I mean, at least right now, there are a few important things that are happening on the ground in Louisville outside of clinics. There's been a lot on social media about a new pro-life group that's in town and things getting aggressive with clinic escorts. I got a call last week from some reporters out of Ohio about some clinics that are closing in southwestern Ohio and concerns about asking us questions about how that might affect women in northern Kentucky. So, I mean, I do see, some interesting things. It was interesting to get those calls from reporters from Ohio and not get any calls from reporters in Kentucky about those issues. So I'm just curious for issues like that, the pressures, or challenges that you face as reporters in covering those issues, or any pushback that you get from editors in covering those issues.
They're about to lose something. If we were in danger of losing one of the clinics in Kentucky, then that would be news. It's the nature of news. There is a current issue on this front, though, and that is the Planned Parenthood funding issue. And the response of the state officials has been that, number one, Planned Parenthood in this state does not perform abortions, and that if you shut down or if you ended Planned Parenthood funding to these clinics, then there would probably be one fewer location in, say, Fayette County. And the fewer locations you have, the fewer people get served, and ultimately you have more teen pregnancies and perhaps more abortions. Actually, the Secretary of Health and Family Services did not quite want to go that far, but we were able to use the Guttmacher Institute to make that point. That's, what's going on that issue now. I don't think there's any particular pushback from editors about it, but you all might think differently.
And I agree that it's basically based on the news that's happening, and I think the Planned Parenthood, like I've written about the Planned Parenthood proposed cuts, as well as what's happening in southern Indiana with the HIV epidemic, and some of how a closing of a Planned Parenthood there affected, whether people could get the testing they needed for HIV. So I think basically when it's newsworthy is when, and I haven't, when there's a news item to write about, I haven't heard any pushback from editors on it. I mean, I think if it's news, they want it in the paper. So
I think if any editors push back on stories about this stuff, then that would be a story in itself, personally. But it may happen. I think that the toughest part of covering this issue adequately is the stigma and the privacy issues attached to abortion and even some of the Planned Parenthood non-abortion stuff. It's finding ways to tell a really human story when people generally and understandably don't necessarily want to share who they are and personal details with you about something like their abortion or even a doctor who doesn't want to put him or herself out there in the New York Times or wherever, given the political climate on this. So that's the struggle that I have, because I like to humanize stories in any way I can and tell them on the ground, and this is a really tough one to tell on the ground.
Yeah, there is some pushback that might come from the lack of appreciation that this is a health story. I mean, this does relate to women's health, and sometimes people just look at it as a purely political thing.
Mary, anything?
I have gotten pushback, but I won't. It was a surprise to me. But I would suggest maybe that you try to contact some reporters specifically and, make an appointment to talk to them or take them out to coffee and to tell the story. I mean, I just think it's not on the radar of a lot of our everyday lives. I mean, I was shocked to find how little access there is to abortion in Kentucky. I think that is something that people don't know because there's so much noise about who's doing it, and if it's the religious aspect comes into play so heavily. So you may be able to make some inroads by just making some calls and talking to some folks, and then those stories would go out on the wire and maybe picked up in other newsrooms where people don't have the time to delve into them personally. So,
Have you had to explain Kim Davis to your fellow Neiman Fellows?
no, they all know, and yeah. Did have to explain the jumper that she wears.
Sorry, communicating with my communications director about what he wants me to say. What I wanted to say was that Doug will be releasing an announcement, actually, to your point. There's actually a big project that's going to be announced at the end of the week, looking at bright spots that's doing exactly what you were talking about, basically identifying communities in the Appalachian region that do very well health-wise despite having challenging socioeconomic factors. So that research hasn't been done. This is looking at that. So wait in here for that. In a couple of years, there will be some new knowledge. What I would say, though, as from the research perspective, be very careful with rankings. County Health Rankings is a great website. However, rankings are relative. So other people could deteriorate, and that's why you go up in rankings, so that it's not a good way to gauge how well a community is doing. And the difference between number 30 and number 3 could be 1 percentage point, which is maybe completely negligible. So be very careful when you look at rankings and don't base stories solely on that relative status.
When I left Kentucky, the Courier-Journal was ranked the 10th best newspaper in America. The most absurd rankings of any kind of rankings were trying to rank newspapers on who was good or bad, but no more. They don't do those anymore, do they?
Hey, I'm Steve Hensley, news director at WYMT. I wanted to ask Al, and the others can chime in as well. Al, what do you think is the biggest story in Eastern Kentucky, health-related story, that we are not covering?
Steve, you'll have to forgive me for not being a regular viewer of Channel 57, but I'm a regular viewer of Channel 27, your sister station, and I presume that they're using some of your stuff on there. I think the biggest story is probably the people who have been helped by the Medicaid expansion. You look at the populations involved here. It's about 400,000 people are on Medicaid today because of the expansion. And I would venture to say that at least 150,000 of them are in your market. And, as I said earlier, we've heard a lot of complaints from people who had to get different insurance policies, and we've had lots of political rhetoric. But the stories of those people have really not been told. And just an example about how political rhetoric tends to dominate these things. We did some research in Appalachian, Kentucky newspapers about the coverage of the Patient Protection and Affordable Care Act. And we found that it was driven largely by Mitch McConnell. Mitch would come to town and speak at a hospital, and the newspaper would do a story, you all might do a story, and then Mitch would write an op-ed, and the newspaper would write it. And he wasn't the only politician that did this, but he was the most assiduous at doing it. And I could give you the exact numbers. It was something like 42% of the coverage was really opinion offered by Mitch McConnell through news stories or op-eds. And that completely obscures the benefits. Now, I think Mitch is beginning to change his tune because he didn't talk at the State Fair breakfast this year about it as he could have easily. He just, made a passing glance at it. I think that the Republican legislators from Appalachia, particularly non-coal Appalachia, where the uninsured rates were really high, have realized it would be politically unwise to take coverage away from a lot of their constituents. And, Robert Stivers made clear that the legislature was going to run the show, but the governor was not. So despite what Matt Bevin wants to do, I think that there's a consensus in the legislature to essentially keep the expansion. Wouldn't surprise me if they included some tweaks, some co-payments, skin in the game kinds of stuff, so Republicans could say they got what they wanted. But taking coverage away from people, I doubt very many people will have their coverage taken away. So the story really is the people who benefit.
You said that last very convincing. You just said now, Tom Birch,
Julie Rocky Adams.
Said no, the governor.
Well, they're just wrong. The governor has the executive power under the 66 Medicaid law, but the legislature can change that law. And it only takes a simple majority of the legislature to override a governor's veto. It doesn't take any 2/3 like it does in Congress.
So Al just gave you a brilliant story there. He's really changing. That is huge. And what a great local political story and national political.
And I also haven't watched your station, so I can't speak about what you have covered. Okay. But I'm based in Louisville, so probably wouldn't get it. But I don't know how much you've done on obesity and smoking issues, especially the local answers to these issues. But every time I go to Eastern Kentucky, it just shocks me. And, you see plenty in Louisville. But, Eastern Kentucky, I think, the more that you can write about those two issues, the better. Another thing is environmental health. Do you do a lot on like mountaintop removal and how that affects? Yeah, okay. Because that's another area where I think there's certainly a whole lot of concern, and it's sort of a national issue that's played out locally as well.
The other thing, latching onto what Al was talking about, that's really fascinating to me to try to measure over time is in places like those counties in Eastern Kentucky where so many people got health insurance, to try to measure any shift in political attitudes toward the law over time. There were so many people last year, at least, who had gotten the coverage but were still hated the law. Couldn't necessarily explain why, but they knew they hated the law. And I'd just be really curious to see if there's even a subtle shift over time in attitudes about the law by people who got the coverage, or even people who didn't but know people who did.
And we actually found that, yes, there is, because we went back to Floyd County a year afterwards and actually talked to some of the same people, including this sandwich shop worker who when we met her last year, or the year before, she was saying, no, I don't want any of that socialized medicine. I hate Obama. I would never sign up for this. Turns out she did sign up for it. She got a plan through the exchange. She went to see her doctors for the first time in years. And she said, well, and she was worried her hours would get cut back as well at the sandwich shop, and they weren't. So she was like, oh, I thought it was going to be bad, but really worked out for me. Of course, some people, still had a lot of bad feelings about it and worries and stuff. But that's a good example of, yes, the attitudes have changed.
And the Kentucky Health Issues Poll surveys this, and you're all in the field. When are we going to see those numbers?
I want to quickly echo something that Laura said a while ago, and this will sound, anything that anybody from Boston says in Kentucky always sounds patronizing, so this is not meant to be patronizing. When I left here, I was for 3 years the environmental reporter at the Courier-Journal, and when I left here to cover environment at the Boston Globe, I saw that there was a huge difference, and what the difference was, I had a great megaphone in Louisville and a good megaphone in Boston, but if I didn't raise a particular issue in Boston, there were 100 environmental groups around that were shouting louder than I could have ever shouted, and I wasn't needed as much there. If I didn't raise an environmental issue when I was in Louisville, or the Courier-Journal didn't, no offense to Lexington or anyone else, it wasn't going to get raised. And I think that you have huge potential here to have more influence than most journalists in most places in America. And that is a function of some of Kentucky's poverty and other things that are going on here, but it makes your role really essential. So it scares the hell out of me when I come back here and see a very pared down Courier Journal. And I don't know if it was accidental, but I was out very early this morning on a walk through downtown Louisville, and you could not see the words Courier Journal. It didn't light up at all, but you could see lit up under that courierjournal.com. And it said to me some of the changes that are going on there. And it just happened that the courierjournal.com is a newer sign, so it lights up at night, and it doesn't matter. But you just have real potential here to do extraordinary stuff. And I think anybody who hasn't asked a question, got lots of smart people who are asking more. So another smart.
Sorry, I'm very talkative. So this is a question I've been wondering about a while since I heard of the HIV/AIDS outbreak in Indiana. How much of that do you think is a result of people getting more coverage? Does that make sense? Like, okay, so is it possible that people already had HIV, but they were not insured and couldn't get tested, or do you think that relates at all? Yes.
I think the big effect is moving forward now that they've been identified as having HIV and signed up for Medicaid under the expansion, there will be a huge difference in their access to coverage for years to come, presumably, for their care. But I did a few stories out of Indiana on that, and from what I could tell, almost nobody who ended up having HIV in that county and the surrounding area already had coverage at the time that they were identified.
I
mean, there could be, but it seemed to be a vastly uninsured population still to me.
I was going to say that the story that I think is undercovered, or a story that you guys could get at in Eastern Kentucky, is the HIV potential explosion, especially as intravenous drug use spreads with the heroin epidemic. Because I talked to a researcher several years ago at UK who said she's waiting for patient zero, essentially, in some of these counties, and when it happens, it's just going to be rampant. Because as they just said, these folks are not the ones who are going to the doctor and being careful about who they share needles with or have sex with, and they're very closed communities. So you've got the same 50 people, sleeping with each other and sharing needles and involved in this life that could be very dangerous for them if HIV gets into that system. And there's a cultural barrier to saying they have HIV, which is true, especially in the Black communities. So I just think that and the spread of hepatitis C, which is sort of invisible for people for perhaps decades, is going to be a huge health impact on Kentucky in the long run. And we may have had real drug problems around long enough that there's some real examples of hepatitis C and how it's straining the medical system, because they need a lot of care once they're diagnosed.
And I agree. And in fact, I have done a story looking at other communities at risk, including Eastern Kentucky, and other rural communities throughout the nation, because another thing that you have to think about too is, what infrastructure is there? And in a lot of these rural communities, there's just not a whole lot available, and the resources are dwindling. So a lot of these folks maybe don't have a doctor. Like that particular city, Austin, Indiana, has one doctor in town, and that's a lot of these places. It actually is shocking to me that something hasn't happened in Kentucky, knowing all that I do about the drug issue. So I'm just waiting for the next thing to happen, unfortunately. But yeah.
The fact that we're number one in hepatitis C tells me it's probably already started. We're probably well past patient zero, but we haven't gotten to the diagnosis level because of that cultural barrier. So, Steve, maybe that's really the better story. And here's why it's important. This is the local public policy question. You can have a needle exchange program in Kentucky if your local fiscal court and health board, and I think the city with the largest population, all have to approve. I went to a meeting of the Woodford County Fiscal Court last month, and the jailer was giving her report and said, yeah, about 80% of our people have a substance abuse problem, and about 60% of those are heroin. This is Woodford County, number 2 in per capita income in Kentucky. And and the ambulance director was there and said, yeah, we're getting 40 overdoses a month, and our naloxone budget's through the roof. So everybody turned to the county attorney, and he said, he didn't say it in so many words, but basically he said that the health board didn't want to touch it. Or maybe it looked like there was some sentiment on the fiscal court to do something. I don't know who's on the Woodford County Health Board, but somebody needs to start covering it. And that's true with almost every other county health board in this state. We've got a law in Kentucky, passed in 1954, I think, that makes public health boards, your county health board, the people who are responsible and accountable for the health of your community. And I don't think many of them actually realize that. The 7 or so health departments that have gotten national accreditation, their boards know it. But we've got 61 health departments in this state, county and district health departments. And they used to be run primarily as political backwaters and place to get your immunizations and so on. That's all changing. And they're going to be doing public health, population health. And you've got some really good health department directors out there, and you've got some others that are pretty lousy still. But the key to make them work are these health boards, which are largely appointed by the county judge executive, and you have to get a doctor and a dentist and even a veterinarian and an optometrist, believe it or not. Shows how good a lobby the optometrists have. They don't do their jobs in most cases. I'll say that publicly. They don't do their jobs in most cases. And they hardly ever get covered by any local news media. So here's a chance to take a current issue, needle exchanges, and put a question to the county health board. Attend every damn meeting until they decide yes or no on needle exchanges. Put it before them. See what happens.
I think. You have a question? Great. So this is going to be the last question, and then.
This is just kind of going back to the HIPAA stuff and putting a personal face on some of the stories. And if you've got a doctor, if you've got a patient who's willing to talk to you, and their doctor expresses maybe some willingness, but of course is bound by HIPAA, how often do you actually maybe ask the patient or the interviewee to sign a release form so that you can then talk to their doctor? Do you use that very often? And especially if they have a concern about how their health care has been, the quality of it. Because then it's going to be one-sided.
I think it's up to the doctor to make sure that the patient signs the consent form. And most doctors who are at all well-versed in this will know to do that. I don't think I've ever been in a situation actually where I've talked to a doctor about a patient's health where the patient hasn't signed a consent form saying it's okay to do that. I think that's where HIPAA actually is a real thing. For me, they usually initiate it. They know going in.
Yeah, and I don't initiate it either. Same kind of thing. It's usually the hospital or the doctor. If any such form is needed, we don't use them. I mean, it's not like I have one and I give it to people. But as far as talking to patients, I often will ask patients to contact their doctor and let them know I'm talking to them. They're okay with the doctor talking about them to me. And most times, if the person is okay with it, the doctor will be okay, unless it's, reflects horribly on the doctor. But at least the doctor knows I'm going to mention it, which you have to, let them know. So,
Mary, anything?
No, not on that in particular.
Okay, so what we're going to do is wrap it up the same way we do all of the sessions, which is just to ask these great reporters to share their most intimate contact details. Mary, if somebody wanted to reach you, is there some way to get through the Neiman barricade up there?
Yeah.
Yeah. What's your current email?
Mary__meehan@harvard.edu. I still get pretty
excited. You never have to give up that email for the rest of your life. You can have it.
I still get pretty excited when I type it in, honestly.
That is exciting.
Yeah.
Thank you, and you've probably got 2 classes and 3 parties to go to there now. Al?
al.cross@uky.edu. The cell phone is 502-682-2848. Just remember these 2 addresses. My Twitter address is @RuralJ. That tweets out everything on Kentucky Health News, which is kyhealthnews.blogspot, blogspot.com.
And mine is Laura, L-A-U-R, or my Twitter handle is @Laura, LAURA_Unger, UNGAR. My email is lunger, LUNGAR, @courier-journal.com. And my phone numbers are 502-582-7190 for my office number, and my cell is 502-409-1540.
My email address is the best way to reach me. It's just abby@nytimes.com. My cell phone is from my Miami bureau days. It's 305-213-1323. I'm on Twitter at Abby Goodenough. And if you guys want to, I'll put in a plug for my series on Kentucky and the ACA. If you want to look at it, Google Remaking Medicine, which was the name of it, and the New York Times, and all the stories are compiled there. And also a really great video that a video colleague of mine did about a guy who desperately needed insurance, but actually ended up not getting it under the ACA for a variety of complicated reasons. So give it a watch if you have a chance.
2 more really quick things. One, I'd love to hear up here if anybody after the session is driving to downtown Louisville. And the last thing is, I would love to thank the foundation for putting this together, for bringing together more journalists than we could assemble in the entire state of California for a day program. And so Doug and crew, thank you very much. And
Great. And I'll send my PowerPoint out to everyone whose addresses we have. Send me your address if you haven't already. I just need to condense it. There's a lot of repeated slides where you're adding stuff, so I'm going to send you a much smaller file that'll be more easier to deal with.
Thank you, Angela. Great. Thank you.
Thank you.